Hi, Dr. Goldberg here, continuing our internal medicine lecture series update. Today we're talking about hypertension or high blood pressure. Of course, we like to keep our blood pressures in adults in the 120s or lower. And then, of course, in the diastolic pressures in the 70s or low 80s, certainly. But 75 million adults in the U.S. suffer from hypertension. 26% of adults in the world have high blood pressure. Of course, 95% of this is idiopathic or primary or essential. Secondary causes include renal artery stenosis, cortisol excess such as Cushing syndrome, hyperthyroidism, pheochromocytoma, and aortic coarctation. We should differentiate a hypertensive emergency from hypertensive urgency. So hypertensive emergency is when there's end-stage damage, such as with a TIA or a stroke associated with a systolic blood pressure of greater than 180 or a diastolic pressure of greater than 120, whereas hypertensive urgency is when there is not end-stage organ involvement, but the systolic pressure is greater than 180 or the diastolic pressure is greater than 120. The consequences of long-term hypertension include coronary disease, peripheral vascular disease, heart failure, diastolic dysfunction, aneurysms, dementia, and chronic kidney disease. We treat hypertension with a variety of different medications. We've used diuretics for years, including thiazide diuretics, as well as loop diuretics. The loop diuretics like furosemide and ethacrynic acid. Ethacrynic acid, of course, does not have sulfa, so that can be nice for our sulfa-allergic patients. We've got our potassium-sparing diuretics, such as amiloride, triamterene, spironolactone, and eplerenone. So, which that drug is like spironolactone, but there's less gynecomastia associated with it. These meds are helpful, of course, in our patients with heart failure. Then we have our ACE inhibitors, but a significant percentage of these people will have cough associated. These are especially helpful in Black patients as well as patients who have had heart failure after MI, and will reduce proteinuria in patients with diabetes. Our ARBs, of course, have a similar profile as ACE inhibitors, but there's less cough. Our beta blockers include labetalol, carvedilol, and nebivolol. Those are the most common ones we use. Then we have our calcium entry blockers such as verapamil and diltiazem. These are vasodilators and decrease total peripheral resistance. Our direct vasodilators include hydralazine and minoxidil. Our alpha blockers peripherally include doxazosin, terazosin, and our central alpha blockers are clonidine. Finally, renin inhibitor like aliskiren can also be utilized. For our Afro-Americans, we like to use diuretics and calcium channel blockers first. When we're in the hospital with patients who can't take oral agents, we can use IV hydralazine, IV labetalol, and IV enalapril. For our patients with gout, we want to stay away from hydrochlorothiazide as well as Lasix. For our patients with heart failure, of course, we're going to use carvedilol or metoprolol or ACE inhibitors or spironolactone. Remember that beta blockers, dihydropyridine meds like amlodipine, and calcium blockers can all cause betal edema. We're going to use thiazide diuretics in patients who have a history of calcium kidney stones. And we're going to use alpha blockers like terazosin in patients who have BPH. Spironolactone is a good choice when rosacea is present in men or women. And minoxidil use will also require Lasix for the edema that you can get from minoxidil, as well as a beta blocker because of the reflex tachycardia. Most importantly, with hypertension, remember diet. We use the DASH diet, which means dietary approaches to stop hypertension, and that can be Googled for a review on that, monitoring sodium intake and that type of thing. So this is just kind of a good summary on hypertension or high blood pressure for you. I hope it'll be helpful as you treat your patients. Thank you, Dr. Goldberg, signing off.